Brief histories of education in nursing and respiratory care. Here are some pictures of respiratory therapy throughout the ages. In the upper left hand corner here is a physician listening to a young child's posterior lobes in what looks like a tube or a telescope. We have here some ventilators. These are actual ventilators from around the turn of the century of the 1900s. It's about 1901. This is a picture of ventilators, iron lungs as they were known in the 1950s. Here we have a picture of some respiratory therapists who would deliver oxygen to homes. This is one of the first earliest versions of a respiratory care practitioner that we know about. And then here are some modern day ventilators. Here is a respiratory therapist with a neonate who is on a ventilator and some monitors, and they are drawing some ABGs. And then this picture here in the upper right hand corner is from the 70s, showing a young lady doing some pulmonary function testing. So the need for a healthcare provider was apparent once the advances in oxygen therapy happened. So once we figured out that we needed mechanical ventilation, we learned how to do that. We learned how to give medications in an aerosolized format, and also learned different types of cardiopulmonary diagnostic testing. It was understood that you needed to have a person who really knew about those things, who was a specialist. So the first oxygen technicians were known as inhalation therapists, and they were oxygen orderlies that transported the cylinders, the oxygen cylinders, the green O2 tanks, and different related equipment, and would set it up. And then when there was the development of positive pressure breathing ventilators during World War II, the role of the oxygen therapist, inhalation therapist, that role expanded. And so positive pressure breathing was developed, the breathing support for high altitude pilots, and also to give aerosol medications. You can have a person who's on a ventilator and there's an adapter that you can add in line with the ventilator that will provide an aerosolized medication such as a bronchodilator, which will help to open up the airways. Respiratory therapy is a much younger profession than nursing, and we are still trying to figure out sort of where we're headed, where we fit in, and where we're going, but there are many advances. We work well with the interprofessional team as well, with nursing and physicians and other members. So the 40s and 50s saw the expansion of the role, as we were just saying, and then actual formal education programs began around the 1960s for respiratory therapists. And then this is how the industrialization or technological revolutions play in, because as technology advanced, as the mechanical ventilators advanced, as there were other diagnostic tests that became available, then the role of the professional expanded, and therefore more education was needed in order to work with the new technology. 1974 was the year where respiratory therapists were actually given the designation respiratory therapist. And before that, there was on-the-job training, but now you have the formal education systems like we have here at Hartnell. Most of the, if not all, of the respiratory therapists that received on-the-job training and were working on the units are all retired, according to Mrs. Brandt right now. But it's interesting to think that it was on-the-job training, and now you have to go to school for 2 years. And the new responsibilities as the role grew also included assessing patients and treating patients. You weren't just delivering oxygen or delivering a medication. You're actually using now evidence-based medicine, evidence-based practice and clinical guidelines, clinical practice guidelines similar to nursing and other professions were developed to provide the direct care, the patient education, to help coordinate with care. And so then that's when you, the designation of therapist, respiratory therapist, as opposed to a technician, where that phrase was coined. So it started out with respiratory education, that there was on-the-job training. And currently here we have the associate degree. You can be a certified respiratory therapist or registered respiratory therapist. We have the RRT here. Respiratory therapy is also looking at making the baccalaureate degree, the BSRT, the minimum entry level, similar to what nursing has. There are now master's programs for respiratory therapists. Ms. Brandt actually received her master's degree last year. And then, similar to nursing, what about advanced practice respiratory therapist or doctoral degrees for respiratory therapists? Well, people are thinking about that. They're starting to open programs. It's hopefully going to be a thing of the future, and that would be good advancement for respiratory therapists. I think there's a lot of information that the therapist needs to know, and things that could be taken to a higher level in terms of education, patient education, medications, different therapies, different technologies, and those types of things. So looking at respiratory education in 2015 and beyond, 2015 was a hallmark year, and so the CRT, RRT was combined, the exam was combined, and then California passed the RRT as a minimum entry into practice. And actually in 2015, excuse me, Skyline and Modesto colleges were awarded the right to pilot a BSRT program, which they started in the fall of 2016 and are still offering at this point in time. And in 2019, of note, is that Hartnell College, the respiratory care practitioner program, received the COARC accreditation, which is one of the highest accreditations. We have one of the best respiratory care practitioner programs in California, if not the US. So y'all are very lucky to be here. Now we're going to move on to a brief history of nursing education. So this picture depicts Florence Nightingale on the left in 1820 and the nurse of today in 2020. And we're going to move into some of the history. The religious orders used to provide care for patients, for people who weren't known as patients back then, but for people. So those were men in nursing. Those were monks, priests, people in religious orders, some women as well. It wasn't until the Crimean War when Florence Nightingale, Lady of the Lamp, who went through the fields, the war-torn areas, with her lamp, providing care to the soldiers there. And so the Civil War here in America brought along the Army Corps of Nursing. We needed nurses in the mid-1800s to help take care of our soldiers during the wartime and as well as rehabilitation after that. There was also the growth of public and home health nursing as well as industrial nurses. What's an industrial nurse? Industrial nurses would be workplace nurses, nurses that, occupational health nurses. Many people went into homes to take care of people, to provide care for the sick. There really wasn't any formal training for nurses. Originally, nursing was taught in the hospitals, and oftentimes the physicians would give lectures to the nurses, and it really, the function of nurses was on training and providing service. So it wasn't, we weren't really looking at concepts or at care of the individual, holistic individual. It was the doctor diagnosed what was wrong with the patient, and then the nurse followed along and followed the physician's orders. There really wasn't much thought given by the nurse as to what needed to be done. They were following the physician's orders. Around the beginning of the 1900s, nursing education standards came into existence, And then there were also more hospital jobs and in the home because they started to, the medical insurance had been invented, which was a good thing, but the focus of nursing care had been in people's homes, and then it moved to the hospital, which is not always necessarily the best place for the person to be cared for or to recuperate. And then when we moved into World War II, again, more technological advances, and so we required better educated nurses, need to know what to do with all these new technological advances. And so at this point, the Cadet Nurse Corps came into existence, and then the nurses were actually commissioned as officers. So 1952, again, mid-1900s, there were registered nurse programs developed for community colleges, which would be the associate degree nursing programs like we have here at Hartnell. And the shifting of education went from hospital programs to actually colleges, institutions of higher learning. There were some schools of nursing that were still affiliated with hospitals. I actually taught at one in Ohio, Med Central College of Nursing, which closed about 10 years ago, and they moved over to Ashland University. This is in Ohio. So they went from a hospital setting of the College of Nursing to a university setting. The IOM report showed that there was an increase, or we wanting to increase RNs that have a bachelor's level education. The goal is 80% by 2020. We're about halfway there. 2019, between 55 to 60% of RNs have a bachelor's degree, which is looking to be the standard of entry to practice. And what's interesting, however, is that all the RN graduates take the same NCLEX exam to become licensed as a nurse, regardless of the program. So whether you go through a bachelor's program or an associate degree program. We also used to have 3-year diploma programs. Those have been phased out. They work better. The ADN programs are 2-year programs. And so it's just a little bit the change in focus, but the basic care is the same. And then if you look at the statistics for the RN graduates in California, the most recent statistics that we can find that have been tabulated are from 2017 to 2018. And it said that 11,890 students completed a pre-licensure nursing program in California. So that would be prior to getting their license. So it could be an associate degree, it could be a bachelor's degree, could also be an entry-level master's program. They do have those now where you start with your basic nursing education and go right into a master's level program. So the it's almost a little bit more in ADN programs, but it's about equal to 43%, 46%. There's only a few percentage difference between the programs. I guess you would have to look at, as well as with respiratory therapy, what is your goal? Where do you want to be? Do you want to teach? Do you want to practice? What is your goal as a healthcare professional? So what's happening now in nursing is that we have seen in order to get students, candidates through to be able to take the NCLEX and to also have their bachelor's degree, we've relooked at the associate degree programs, and so there are fewer units now in the associate degree program. We don't have as many courses, or we have the same courses, but they are less units, because we have what are called dual enrollment programs in associate degree and bachelor's programs. So for example, if you are a student at Hartnell, once you are in your second semester, you can apply for CSUMB, and we do have people come and talk to you about that, so you know how to do that. And so you're actually dually enrolled. You're taking the program here for your second, third, and fourth semester, while you are also taking one class at a time at CSUMB. Then when you graduate from Hartnell, you continue for one more year and finish with your bachelor's degree, which is great. We have a lot of students that do that. You don't just have to attend CSUMB. There are other programs. Boise State is one. Ohio University is another that are online programs that you can take as well. Magnet status for hospitals is elevates nursing, the profession of nursing, and it requires that you have a majority of the registered nurses in your facility to be bachelor's prepared nurses. What we really need is RNs that have the same ethnic background as patients. When I go into the hospitals here in Salinas, I am not fluent in Spanish or Tagalog or any of the specific Spanish dialects. So we have to get translators to the floor, which takes time, and it can be distracting. Sometimes the physicians don't want to wait, but it's actually the best thing for the patient to be able to communicate, to speak with somebody that speaks the same language, has the same cultural beliefs, the same ethnic background. To see the smile on the patient's face is really quite amazing, and it also helps with their healing process. So finally, some trends affecting nursing and respiratory care education. We talked about a little bit, sort of a summary. So evidence-based practice is big. That's how we're expanding our knowledge. What has been done in practice? Does this work? Does that work? Yes, no, ooh, let's try this. Okay, this is what works now. We've done studies. We've shown that this is a better way to do it than what we have done in the past. The explosion of technology, the technological revolution, the 4IR, if you will, the fourth industrial revolution. We have electronic health records now, electronic medical record, electronic health records, which is why we have HIPAA, which also has to do not only with privacy, but portability, being able to take your healthcare information wherever you go. The socio-demographic and cultural diversity, we're much more diverse society these days. Many different economic, political, legal changes, different laws that affect people. Even the pandemic that we're going through right now, all the laws or things that need to be followed to stay safe. The consumers, you as consumers, myself as a consumer, everybody out there, we're all consumers, much better educated as a result of technology, and it's a very consumer-oriented society. So for example, you can have a patient, back in the day, I've been a nurse for about 32, 33 years, you would educate your patient and say, this is what you need to do, make sure you take your antibiotic, until it's gone, take your temperature, call your doctor if this, that, or the next thing happens. Nowadays, the patient can look, or their family can look up all the information online. So they are much more educated, and they will come to you with questions and say, well, why do we have to do this? Or this reference says that we should do this, and this resource suggests this. What do you think we should do? So we have to be very careful about that. But what that also means is that we've become service-oriented. Hospitals actually receive funding based on their patient satisfaction scores. So that would apply to anybody in the hospital that was providing care to patients. So those are just some things to be looking out for. This is an exciting time to be in healthcare, and I look forward to seeing you all grow through the next 2 years. Thank you so much.